Welcome. I'm Dr. John Stone. I'm the executive chairman of the IgG4-RD Foundation, and it's wonderful to welcome you to our Fireside Chat about retroperitoneal fibrosis, a problem that afflicts a major proportion of patients with IgG4-related disease in an area of great unmet need. We hope to chip away at that or make great strides at understanding retroperitoneal fibrosis in the coming months. So part of our program is to focus on it by having a fireside chat on it today, and I'm delighted to welcome our guest, who is Dr. James Tomlinson, who is a nephrologist at the famed Hammersmith Hospital in London. So welcome, Dr. Tomlinson. Welcome, James. Thank you for joining us today.
Well, thank you, John. Thank you so much for the invitation. It's a real pleasure to be here. So it's my first time, so it's a real honor.
Well, we look forward to your insights. I'm looking forward to the discussion, and we'll intersperse questions for you with some videos that we have of real-world patients. And before we start, I wanted to declare the IgG4-RD mission statement, which is to enhance the lives of those within the IgG4 related disease community through education, awareness, and research, and to serve as a trusted source of truth about IgG4 related disease. Before we get into the program fully, I have three quick announcements. One you may have already seen on our website. It is about our next patient-facing jamboree, an in-person meeting for the IgG4 related disease community. This will be held in Atlanta, hosted by Professor Arezou Khosrowshahi at Emory. It's coming right up in under 2 months now, September 12th and 13th. Registration is live. And in fact, at the end of our program today, I'll put this QR code up on the screen again and leave it as the program finishes. This QR code will take you right to the registration page, and registrations are mounting very quickly. I am delighted to report. So that's one announcement. You'll be hearing more about the PeachJAM shortly. Second is that we are almost ready to launch IgG4Me. This is an app that the foundation has developed in collaboration with a company called Mijo, and the app permits people living with IgG4 related disease or their caregivers to manage, track, and share their health information. In the interest of keeping it all together, patients have very complicated histories, typically lots of physicians, lots of other care providers, and lots of data. And IgG4Me will facilitate your keeping all of that together and facilitate the coordination of care. One of the questions that we have today relates to the coordination of care. So I'll mention that again when we are answering that question. And the third announcement is of an upcoming first for the IgG4-RD Foundation, and that is a bike ride, the Great IgG4-RD Bike Ride, which is a fundraising event, a fun and a fundraising event that we are participating in Vermont, in the little town of Peru, Vermont, on Saturday, October 4th, this fall. And this gorgeous picture you see was actually taken on the occasion of the event last year by Catherine Provencher, our Director of Patient Advocacy and Community Outreach, who participated in the ride last year. She promises that the weather will be just as spectacular this year as it was last year. We will be providing you a lot more information about the Great Bike Ride soon. So stay tuned. So as we move into the program, I want to thank at the outset three people living with IgG4 related disease and one caregiver, all of whom have contributed to this program. And they are Mr. John Durkin, Mr. Circus Kaya and his daughter, Miss Lisa Uslek. Lisa translated for her father, whose native language is Turkish, and Ms. Donna Ship, who is a nurse and also person living with IgG4-related disease and retroperitoneal fibrosis. So thanks in advance to all of you. So we're going to start with a little video clip here from Mr. John Durkin describing his first symptoms.
You live in Jamaica Plain, where the famous Jamaica Pond is, and I understand that was the scene.
Yes, that was the beginning of the story. You take a walk almost every day around it. It's just such a beautiful spot, good exercise, relatively flat, so not too vigorous, but a nice 2.5-mile walk from my house. And I'm doing my thing, feeling fine, and all of a sudden, out of the blue, I just get this sharp stabbing pain in my left kidney area. And I had heard about kidney stones before, and this had all the hallmarks. I mean, just bend over, crippling, need to sit down, nauseous kind of pain. And I found a bench and sat down and was there for like a half an hour. And I'm thinking, should I call my wife to come pick me up? And I finally made it home.
So it was just like someone had stabbed you.
Yes.
In the left, in the flank.
And I had a friend with kidney stones, and I'd heard a little bit about it, and I thought, this is what it feels like. So I went home, tried to lay down. I really couldn't get comfortable laying down, which I guess is another symptom of kidney stones.
Renal colic, they call it.
Okay.
Yeah.
Well, probably shouldn't have done it, but I took a fair amount of ibuprofen, and the pain calmed down throughout the night, and went to work the next day. It was still with me, and throughout the weekend, it just kind of gradually calmed down. Wasn't a problem. I was taking ibuprofen, and maybe a week or two later, I was back to normal.
So you just thought you had a kidney stone, and it had passed.
Yes.
Slowly got better over a period of weeks.
Yes. Yeah.
So what was it that caused you to finally go and seek attention about
a month later, I had my annual with Dr. Lambert. And one thing I did notice, my blood pressure was spiking, and I'd been on it. Dr. Lambert had wanted me to go on blood pressure meds, and something I was trying to avoid. But this was up. My blood pressure was elevated, and I went in to see him, and he prescribed blood pressure meds. And as I'm leaving, anything else, I said, oh, about a month ago, I think I might have had a kidney stone. Described the situation, and he added to the blood work some kidney function tests. And when it came back, sure enough, my kidney function was way down.
Okay.
So got a set of questions here quickly for Professor Tomlinson. And James, thank you so much for joining us again. Maybe before I ask you the first question, you could tell us just a little bit about the setting in which you see patients in London at Hammersmith.
Yeah, and again, thank you for having me. So in London, we've had a dedicated retroperitoneal fibrosis and IgG4 clinic. We run it simultaneously because, of course, as most people have either suffered from the condition or managing the condition, know that there is an overlap between the two conditions. And we've been running that clinic for over 10 years now, and it's really embedded in our vasculitis clinic. So there's a wider umbrella term for disorders of the immune system that tend to inflame the kidney and other parts of the body. And so I'm one person in that. So we manage all types of vasculitis, but that's my role to look after the care of IgG4 and RPF. And it's a really enjoyable specialty to be involved in, because we have many other specialties involved, from rheumatology to urology and various other specialists involved in people's care. So we have what we think is a very well-rounded opinion, and that's crucial when we're trying to get the diagnosis correct and obviously manage some of the complications and symptoms.
So do you actually have urologists in the clinic with you and rheumatologists in the clinic with you?
Not so much. So it's actually in the clinic we have rheumatologists with me as a nephrologist. But we have an MDT. We call them MDT, so multidisciplinary meetings, every 4 to 6 weeks. in which we do stay in the same room, or now post-COVID, more and more actually online, but we share the same space to go through people's cases, discuss the presentation and their symptoms, and then look through their imaging and other data to really come together with a well-rounded opinion on what kind of condition we may be looking at and how we can best address it between the different specialties. So yeah, in that we have probably 6 to 7 different specialties involved as a core group. But then of course sometimes we get very atypical presentations needing other specialist care, such as ophthalmology or some less common presentations, and that's for IgG4, of course. But retroperitoneal fibrosis, I think you really do need a urologist, of course, a nephrologist, rheumatologist, and sometimes a team or a representative from the vascular team as well sometimes.
Brilliant. It's nice to hear about that setup. Multidisciplinary care really is required for so many patients with IgG4-related disease, probably more for retroperitoneal fibrosis than any other, one can argue. My first question for you is about Mr. Durkin's presentation. He had sudden onset of flank pain over the kidney, very intense. Is that a typical presentation of IgG4-related retroperitoneal fibrosis in your experience?
Honestly, no, it's not actually. I think anything goes, but in our experience, and this is of course most people, because of course there are exceptions to the rule, but I think what is common is more of an insidious creep of symptoms actually. Of course you can have little peaks of pain or peaks of symptoms, and then they tend to melt away, but as a general rule, a slow progression of symptoms. And that's really difficult for the person to get a hold of in terms of trying to understand when it actually started in the first place. In addition to pain, what is very common is other fairly non-specific symptoms, i.e. symptoms that aren't clear about what's happening. So these can be just fatigue or tiredness, or even a bit of weight loss, but not dramatic. Or what is common also is abdominal bloating, and change in bowel habit. And of course, any of these symptoms, we all feel these symptoms at some point, and they can represent no problem at all that will just melt away, or they can represent other conditions that are far away from the diagnosis of RPF. But sudden pain is not that common. Of course, it can happen, as we just heard, but that's not a common presentation. And it tends to be a slow progressive thing that will eventually cause someone to present to a doctor or nurse to go through their symptoms.
Well, your response, I think, underscores the reason it's so difficult to diagnose this problem, because it can present in very non-specific ways, bloating, etc. Changes in bowel habits can make it very difficult to diagnose. So not surprisingly, it is actually many months before a lot of these patients are diagnosed. Mr. Durkin had perhaps somewhat atypical presentation, but the dramatic nature of that led to his earlier diagnosis probably than most patients. Even so, it probably took at least a month before he was diagnosed. He mentions elevation of blood pressure, and that was one of the things that led to his diagnosis. His primary care doctor had observed that in clinic. What causes elevation of blood pressure in this setting?
That's a really good question, and actually quite complex, but there are some general principles to think about and consider behind blood pressure, or the relationship between blood pressure and kidney distress. So the kidneys are best seen as almost the waste filtering units of the body. So they operate like sieves effectively. So they sieve the blood, and really they're great markers and monitors of what's happening in the body. So they really sort out what the body does and doesn't need in terms of fluid, in terms of salts and different proteins, and all the waste products that our body produces during digestion and daily functioning. So they filter the blood, and into the urine they produce as much water that your body doesn't need, and these excess salts and metabolites. And of course, what happens is if you get some kidney dysfunction, i.e. the kidneys aren't working so well for whatever reason, it can't sort out that proper monitoring and filtering system so well. So what happens is you get accumulation of fluids, accumulation of some metabolites that can be a bit toxic to the body in many different ways. And you get rises in some hormones as well that can stimulate a higher blood pressure. And so what we see in almost every form of longer term or chronic kidney disease, for whatever reason, is it's almost always associated with a higher blood pressure. And what we do know also is that relationship goes in two ways. It's bidirectional. So kidney disease can cause high blood pressure, and high blood pressure can cause kidney disease. So they accelerate each other. And when you're in that cycle, over really months and years, is a long-term cycle, but that cycle is a vicious cycle. So one feeds off the other. And so you have to obviously try and break that cycle by diagnosing what's causing the injury to the kidney, in this case, retroperitoneal fibrosis or RPF, but also take a handle and monitor the blood pressure and manage that often with 1, 2, 3, or sometimes 4 medications to control the blood pressure and therefore further protect the kidney function.
So it is complicated, as you point out, and I'm not surprised by your answer, involving fluid overload and electrolytes and sodium and hormones. But the point you make about the importance of addressing it very conscientiously, even requiring medications and often more than one medication, is really important, because high blood pressure can contribute to further renal damage over time. So let's take a quick look. This illustration it's very important to have sort of as a background to our discussion. So here are the kidneys, one kidney here, one kidney here. This is the aorta, and the inflammation associated with IgG4-related retroperitoneal fibrosis tends to occur around the aorta and then down around where the iliac arteries split off from the aorta. And this anatomy is very, very important because the ureters, which carry urine from the kidneys to the bladder, cross the iliac arteries on their way. And if there is inflammation in this area extending down to the iliacs, very often that inflammation entraps the ureter, leading to the condition of hydronephrosis, which is blockage of the urine flow from the kidneys to the bladder. James, do you think it was that which led to the pain? Is that which triggers the abrupt pain that some patients with retroperitoneal fibrosis have, that hydronephrosis?
It is likely, isn't it? So a lot of the urinary system isn't actually well innervated with pain fibers. So part of our nervous system supply sensation and other functions, but also pain. And so around the kidney, there are not too many pain fibers. There are around the capsule. So on that great diagram you've got shown there, the kidneys are covered in almost like a sausage skin, what we call a capsule, and that's innervated with pain fibers. So if that stretches, that causes pain. So a common cause of pain, of flank pain or kidney-related pain, is having that stretched by an inflamed, swollen kidney that you sometimes get with infections. But then the other bit that's got some pain fibers connecting to it is that tube that drains the kidney. So you can see that ureter at the top, the tube that drains the kidney. That's right. So that's got some muscle fibers and some pain fibers there. So when that stretches and compresses and squeezes, typically against the stone that Mr. Durkin was thinking that he may have had, that is when you get terrible pain. And that's really well documented to be a really severe pain. So when that squeezes and against stone or other problems or an obstruction even, then that causes terrible severe pain. And it's up there, I'm told, with childbirth. Not that I can say, given I'm male, but that is a very well documented to be a really severe pain where you are, almost doubled up. So yeah, I think it's likely that Mr. Durkin suffered some ureteric contraction and therefore terrible pain.
So there's much that we don't know about this process. There's a lot that we have learned, but there's still a lot that we wish we knew. One of the things we don't know is why the inflammation tends to occur most often in this area. That is where it happens in most patients, but it's also possible to see it in other parts of the retroperitoneum, even down in the pelvis and at other places around the kidneys. So we really need to understand more about the natural history of patients with retroperitoneal fibrosis. We've got one more image to share with you before we move on, and this is a CT scan, which illustrates radiologically what we've just shown you with that diagram. So here is some of the organs are highlighted here. Here is the liver. Here is the aorta, which was in pink on the previous slide. And then here on both sides of the aorta is this retroperitoneal fibrosis wrapping around the aorta. We refer to periaortitis because of the location. And you can see that the inflammation does actually extend down to cover both iliacs, and that's where the ureters cross. This patient actually had to have a ureteral stent on the right side because of hydronephrosis. And then here is the bladder, the ultimate destination of the urine after it leaves the kidney. It's important to keep this drawing in mind. So let's move on. Mr. Durkin's presentation was not classic, not typical of all patients. And the presentation of Mr. Kai is a little bit different and underscores how difficult it is to get to the diagnosis sometimes. So here is Mr. Kai joined by his daughter, Lisa.
Doktor Suzan Brek sağ olsun o ameliyat yaptı 2 sefer.
So the first symptoms when he was having the pain, because he's an auto mechanic, we always thought it's a muscle pain. You know, he had a heavy job and all that. So we didn't really think much will come out of this pain because here and there he used to get the back pains, and we thought it was just a very, back pain. But when the pain was not getting better, we took him to a primary care doctor who said, let's do an ultrasound, see what it is. The ultrasound showed hernia.
A hernia.
So we said double-sided hernia. Let's see if maybe we could do a surgery. So he actually ended up with the surgery, hernia surgery.
Inguinal hernia surgery.
Correct. On both sides.
Okay.
But the pain never got better.
Okay.
It only got worse and worse and worse, where we had to visit multiple emergency rooms. And so we were so new to the country, didn't know much hospitals. English was very limited. Thanks to some family members, took us to emergency room, but they thought it's a muscle pain. They were giving him pain medicine through IV.
Okay.
After that, once the pain disappeared, he was perfectly fine. There was nothing wrong with him. He's like, oh, I feel great. We were coming home a few hours later, same thing.
Okay.
Very sharp pain, extremely sharp pain.
Imaging studies?
Not then.
Okay.
Not at the emergency room. The imaging studies happened after it only got worse and it was not getting better with any pain medicine and over time. Because they saw if it's a muscle, it might take a few weeks and it will get better. But it was only getting worse. The pain was really getting worse to a point he couldn't walk. He couldn't work anymore. I had never seen him so sick before in my life, and I always seen him like a strong man, always goes to work, never complained, never visited a doctor until then. He was very healthy.
So Mr. Kaya's experience is a little bit different, more long, drawn out, again, associated with pain, perhaps because of dilation of the ureter, because of blockage. Mr. Kaya also had hydronephrosis. Maybe it was dilation of that renal capsule, the capsule that surrounds the kidneys, as Dr. Tomlinson mentioned, but a different presentation. Not every patient presents the same way. So this raises the challenge of differential diagnosis. And James, I wonder what kind of misdiagnoses are common in your patients. What are they misdiagnosed with before they get to you? I'm guessing that most of them have been through 1 or 2 or 3 misdiagnoses.
a really good question because it is sadly so common. And there's a number of levels to this. I think fundamentally you've alluded to it already, but it's worth highlighting that you can't really diagnose retroperitoneal fibrosis or RPF or periaortitis without what we call cross-sectional imaging. So you really need a CT or an MRI because there are no clear specific symptoms or signs that will lead you to a diagnosis without seeing inside, seeing what's happening inside the body's anatomy and the structures. And so a lot of delayed diagnoses are due to these non-specific symptoms and not getting to the point of getting an imaging test. So it's very easy to put it down to perhaps a urinary tract infection or a UTI, renal colic, or that pain that we're describing around the stone that's migrating down from the kidney down the ureter into the bladder. So these presentations are often put down to that and may or may not get the imaging test. So until people get the imaging test, and the diagnosis is really quite up in the air, and you could come back with anything. And I think the problem is there are often, sadly, repeated encounters with an ED department or what we call a general practitioner, community doctor with these symptoms. They get some antibiotics or pain relief and get sent home in case it should just get better with that therapy. And so sadly, it's not uncommon for people to suffer repeated encounters until they get that imaging test, and then you're on the way to a good diagnosis of RPF. And so that answers one part of the question. Do you want me to shall I carry on to the next step? I didn't want to
no, I
go on talking for too long.
That's good. We'll come back to differential diagnosis later on, but your comments are really crucial because with all patients seeing physicians, the physician has to decide very often, do these symptoms rise to the level of significance and worry that I'm going to order an imaging study, that I'm going to make the patient stay longer so that they can get a CT scan or an MRI. And when there are symptoms that are very nonspecific, very often they don't rise to that level of perceived importance. So patients just sort of get passed on for a while before they get to diagnosis. But eventually, they do get to an imaging study. And when they get to an imaging study, what is often seen is an abdominal mass. And the patients we interviewed all experienced this. It was really quite striking. Here's Donna Shipp.
I had severe right hydronephrosis around my kidney, which was completely unexpected because I had no pain in that area. I wasn't having any issues.
Since everybody is not a healthcare provider, what is hydronephrosis?
Basically a buildup of the urine outside of the kidney because there was some sort of blockage where the urine wasn't draining from the kidney into the bladder. And when that happens, it kind of just gets backed up and it can form a pocket outside the kidney where it just kind of sits.
Okay. So when they found that unexpected finding, did they do anything immediately? Did they feel like you needed a stent?
So the first thing they did was order a CAT scan because we needed to find out why I was having that issue. And I just immediately thought that it must be like a kidney stone that was just too big to make it down the ureter and kind of got stuck there and just backed things up. That would be like the logical thinking. So we went for a CAT scan, and it was when we got the results of the CAT scan back that showed that there wasn't any stone present. It was actually, there was a blockage further down in my ureter, the tube that connects the kidney to the bladder, that was causing the backup. And in that report, radiologist had said that it was highly suspicious for a malignancy, cancer.
So Donna is a nurse, and you can probably tell that by the way that she speaks about her issue. Mr. Durkin, when he had an imaging study, also had a mass found.
The mood changed, and everybody was great. Nobody, and I think he said, we don't know what it is. So, kind of, it's, we're not going to use the C word.
So he didn't jump to cancer. That's
right.
Yeah.
And my kidney function was way down. So the big thing was getting the kidney working again. So we knew the left kidney wasn't functioning properly, and saw a urologist, and I was stented in the left ureter.
So they put a stent in
Yes.
into the ureter, through the penis, through the bladder, up into the ureter, and fortunately they were able to get the stent through the blockage and relieve the hydronephrosis.
Yes, yes.
So abdominal mass anywhere raises great concern with patients. Here's how Donna reacted to her news.
So what in the world went through your mind when you saw the report that said highly suspicious for malignancy?
It really took my breath away, because being a nurse and reading reports and having, looked at all sorts of reports from patients over the years, I know that they don't throw around words carelessly, right? They're very careful of what they say. And so to see the word malignancy was just like my heart sank, because this wasn't even on the realm of possibility what I was thinking this might be. I was totally blown away.
So regardless of what type of IgG4 related disease you've had, this will strike a lot of familiar chords. IgG4 related disease tends to cause mass lesions, and that is in the retroperitoneum, as in any organ that can be affected by this disease. And it is striking how often we hear this story. The same was true for Mr. Kaya.
The first thing they said is it could be cancer. And it was really bad. It was shocking. We didn't expect that, actually. But that night, he was one of his worst nights. And he was actually in such a bad condition. He was laying on the sofa, shivering, high fever, and stabbing pain.
Oh.
It was one of the worst nights ever. And luckily, one of his cousins stopped by that night and said, have you guys ever taken him to Mass General? And I'm like, where is Mass General? I don't know. I'm 21 years old, just brand new to the country. I have no idea. He's like, let's go. So we took him in, rushed him into the emergency room, and told the doctor on call regarding, all the CAT scan results and everything. And he's like, okay, there's a mass, but it could also be internal bleeding. And if that's what it is, we need to take him into surgery right away. They took him in, did an MRI. Thank God it was not an internal bleeding. But he said, I really think he needs a biopsy done. Yes. So we had to schedule him for a needle biopsy.
So all of these patients were told that they might have cancer. Our patients hear this again and again and again. So this is certainly one of the major things in the differential diagnosis. But it's not easy getting to the right diagnosis, is it, James? I wonder if you could talk about, even confronted with the findings on radiology, what are some of the challenges in getting to the diagnosis of retroperitoneal fibrosis, IgG4 related disease, even if you see a mass?
Yeah, that's a really key question for this whole session, actually, because for anybody, patient, carer, clinician, looking at the condition of IgG4, the wider condition of IgG4 and RPF, probably the most difficult thing is to make the right diagnosis. That's the biggest challenge, because it's not easy. Even when you've got to that stage of having the imaging, okay, we know there's some thickening around that aorta that you've nicely illustrated earlier. We need to be pretty sure we've got the diagnosis correct for all kinds of obvious reasons. But one is that the treatments are clearly very different. If there is an infection, such as we didn't mention, possible tuberculosis can present in similar fashion. You've mentioned cancer, and that's obviously a key diagnosis we don't want to miss. And there could be a different number of cancers underneath that may associate with such a picture. They're the two most common other diagnoses that we need to exclude as best as possible. And if we're ever in that position where we are uncertain of a diagnosis in many branches of medicine, we often talk about this phrase of a tissue diagnosis. So getting a piece of tissue of the abnormal area and looking at it under the microscope is such a powerful tool, because what it tells us is the kind of cells that are under the microscope, what the structure of the tissue is like, and whether it's clearly abnormal or abnormal. But then we can do lots of other subsequent special tests to stain for different proteins and compounds to understand what the disease process is. And that's probably the most powerful tool. But of course, that's not always easy. There is a risk with biopsy because, of course, you normally go through the skin and use a needle to biopsy some of that material. Occasionally, if people are having surgery for other reasons, that's an option, actually, and that's usually a better approach if there's surgery happening for other reasons or related reasons. Then actually the surgeon can, under direct vision, take a piece of tissue, and you often get a better sample if you imagine a needle biopsy is a very small, thin thread of tissue. But it often provides a diagnosis, but much better to have a larger piece of tissue if that's at all possible.
Very nicely. Yeah, I'm sorry, go ahead.
Sorry, I was just going to finish with, of course, the main pattern of disease we see in RPF is, as you described, that inflammation around the aorta, and the aorta carries your blood through your body. It's high pressure, and so there is a risk of bleeding in a significant fashion if we don't take a safe approach. And sometimes, quite frankly, a biopsy is not possible because it would be deemed to be unsafe because the risks are too high of complications. And in that scenario, which is fairly common, I'm sad to say, it wouldn't be safe to proceed to a biopsy. So we have to go without a tissue diagnosis. Perfect.
I'm glad you're doing and encountering the same kinds of challenges on that side of the pond that we do. Tissue is the issue is a phrase that I learned as an intern, but as you point out, for the many reasons you point out, it's not always possible to get tissue. The radiologists are often very leery of going near that aorta with a needle to get a biopsy, and even if they get a piece of tissue, it may not be big enough to be diagnostic. And very often, the pattern of inflammation, if it is classic around the aorta and involving the iliacs as well, then I am often comfortable making the empiric diagnosis and just going ahead and treating, as long as the radiologist doesn't see something that is alarming in some other way. If they feel like it's highly compatible with retroperitoneal fibrosis, then very often it's not possible or even necessary to put a patient through a biopsy. If the location of the inflammation or the mass is somewhere else in the retroperitoneum, then those are the ones where, in my experience, you really have to push for a tissue diagnosis. But it's a conundrum all the time. No discussion of retroperitoneal fibrosis would be complete without a discussion of stents. And so let's go to that next.
Mm-hmm. Kidney function was really bad. We went to see a urologist, and he said that he needed a stent.
Okay.
So he had a stent in for the next 10 years.
Do you remember having the stent placed?
İlk stentini taktığını hatırlıyor musun diyor. Stent.
Kaç sene?
Ama yani onun ağrısını, onun şeyini hatırlıyorsun diyor, stent ameliyat olduğunu.
İşte ilk stent bu taraftan koydular kaç sene. Yeah. Her 6 ayda bir değişiyorlardı. Doktor McGovern. Yeah. Yani güzel değildi. Epey bir zaman geçti çünkü çok 20 sene oldu neredeyse.
Yeah. He said he does remember. It was not fun. It was not fun at all. It was very the procedure itself was easy. It was very short. But after the procedure, that 1 week was tough. He had always the UTI, literally bleeding blood,
right,
and painful urinating. For 1 week, he was suffering. And he had it done every 3 to 5 months for 10 years. It was to a point everybody at the surgery room knew us. Father and daughter are back, father and daughter are back. Everybody knew us there. And he had it for like 10 years. But also he had, the Dr. Briggs did prescribe him for prednisone too at that time.
So he was on prednisone.
Correct.
He was on narcotics.
Yes.
Too.
Yes.
And he had the indwelling stent, which had to be changed every 3 to 5 months for the next 10 years.
10 years.
stent for 10 years. Mr. Durkin also had a stent. Here is his experience.
What happened with the stent? And the
Well,
rest of the
I was stented a couple times. I think the shelf life was about a month, maybe a little bit.
Few months, yeah. Every 3 or 6 months, the urologist.
Fairly often.
And how is that, having a stent changed?
Well, having one put in, the first night was really tough.
Yeah.
It was urinating blood and just really painful. But I think over time it became pretty okay.
A little bit easier?
Yeah.
Yeah. Okay, so you had several stents put in.
Yes.
You still had a stent in when I saw you?
Yes.
Okay.
So James, I don't have conversations with patients about putting stents in most of the time. They usually have stents in by the time they get to me. But how do you approach that with patients? How do you broach the subject of needing a stent?
Like many things in medicine, I think the most important thing is to explain exactly why we need a stent and what it involves, because of course, why would anybody that's not practicing medicine understand the basis and the anatomy? So we can't expect anyone to consent to it without having a full understanding and what it means, both for the procedure for insertion, but also how often they need to be changed and what to expect when you have a stent in. And it's a real mixed bag in terms of people's or patients' experience with stents. Some people don't experience much at all, i.e. when the stents are in, sometimes both sides, sometimes just one side is necessary. Sometimes people don't experience anything at all and tolerate it very well. But what is more common is a degree of flank pains, a bit like the same pains that present with RPF itself. So often flank pains, so what I mean by that is down towards the back and the side, sometimes going down to the groin, often precipitated by movement as well. So in the morning as they get up and then start to become more active or walk around a lot or do more exercise, they might notice a bit more stent-related pain after that. And on the same basis, seeing a bit of blood in the urine is quite common. Not in everybody, but seeing what we call rosé-coloured, not wine, but urine, or sometimes clots in the urine is not uncommon as well. And then, of course, with that is a high risk of infections. So high risk of urinary tract infections because the body, as most of us know, doesn't like foreign bits in it, i.e. if you have plastic in your body or something that's not biological, that can be a nidus or an area of infection that bugs can attach to and develop into an infection in that area. And so for stents, that would be an infection in the urinary bladder and up into the ureter, sometimes involving the kidney. So infections can be frequent, but they can also get more severe because of the stent just being there.
That's why they have to be changed periodically, every 3 to 6 months or so, typically.
That's right, yeah. So anything between 3 and 6 months usually. And they not only is the infection risk, but they can encrust, if you like. So they have a bit of debris, a bit of sometimes crystals attached to the stent that can reduce the urine flow. The urine actually flows down the stent internal and then around it as well. So the urine can start to slow down as it flows past that if it's encrusted. We call it encrusted. And when you take it out, it looks like just that. You have a crust of salt crystals and protein debris on there. So they do need to be changed for that to reduce the risk of infection, but also to maintain flow of urine. And I think what's really powerful in having a team of urologists involved and interested in this condition, they understand the need sometimes for long-term stents. And there are other options in terms of different types of material of the stents. So certain types of metal stents can be used. And these can sometimes be a life changer for some people who have terrible stent-related symptoms. So going from plastic stents, which are usually what are used in the first instance, you can switch to metallic stents, and they are better in many respects. They tend to cause less symptoms, not symptom-free as a guarantee, but often cause less symptoms. And also they can be left in for longer. So they are changed on an annual basis. So that can be a good option if it works for the patient.
So you've told me a couple of things that I didn't realize, and that is that the urine flows around the stent as well as through it. That's interesting, but the stent is critical to keeping the ureter open. And then tolerability. of the different stent materials, with the metallic stents actually being tolerated better than plastic stents sometimes. It's important for people to realize that there are stents made out of different types of materials, and the metallic are tolerated better. I hadn't realized that.
That's right, and I do think that's exactly why we have a really good relationship with the urologists, because they can both in the MDT meetings, but meet the patient and talk through what options might work better for them. So it's so important to have the urology team heavily involved.
And we'll get to nephrostomy tubes in a bit. But before we get there, I wanted to talk about side effects of treatment and hear from our patients. So here's Donna.
So originally, he had explained to me that typically what he does is start people on steroids, and if that responds, that's good. If not, they do the B-cell repletion. But he said because my condition was so severe, he was going to do it both at the same time. So we had started the steroid treatment and then had scheduled for the B-cell depletion infusion. And we started that.
All right. Did it all melt away?
No.
Okay. What was the response?
So I did feel better on steroids, that, definitely helps you feel better. And I noticed that, like, even though before I'd had surgery, I really didn't have any symptoms that people typically feel with retroperitoneal fibrosis. After the surgery was over and everything was kind of removed, I was starting to feel, I would describe as like the tissue pulling now, because now there was more of an empty space. And I was starting to have more pain. And so I did the B-cell repletion. And a couple of months after that, my pain was getting much, much worse.
Oh.
To the point where we figured it didn't work. We're going to start back on the steroids to try and calm that inflammation down. And that was where I started a 3-month course of steroids after that.
Okay. And how has that gone, the steroids?
It definitely worked in the sense of it helped, the pain and the inflammation. But obviously the steroids come with its own fun side effects. I gained a lot of weight, and I had,
how much weight have you gained on steroids?
I wasn't good.
But
no. But I knew I gained a lot of weight, and I'm sure my mood was really affected, although I probably didn't tend to see it myself. And then my A1C, my hemoglobin A1C was elevating to the point where now I was a pre-diabetic, and I hadn't been before.
And Donna also had a bone fracture in her foot that was attributed to steroids. Mr. Kaya also had issues with treatment.
In 2010.
Yes, that's when we came to see you.
Right.
Because he was on prednisone. He didn't like the prednisone because of the side effects. His glucose was 400. And we said, and he was losing weight every day. So that's when I realized, because that was one of the side effects of the prednisone. They said, pay attention to that, because that's number one thing.
Yeah, steroid-induced diabetes.
Exactly.
Yeah.
And then they, thank God they didn't put him on insulin right away, but they induced, they started inducing the dose of the prednisone and put him on some medication for his glucose level.
Right.
And then he went back to normal, which he didn't need the insulin after that.
Okay.
But the stent was, I think, his biggest complaint in the 10 years, because that was really, really uncomfortable.
Very uncomfortable.
Very uncomfortable.
And so narcotics for that.
Yes.
And the prednisone, I remember he was on 10 milligrams a day when we met, and I was kind of astonished that he'd been on at least 10 milligrams a day for more than 10 years.
Yes.
And whenever they tried to taper lower, his pain would get worse, the problem would get worse.
Correct.
So that was the condition when we met.
Yeah.
James, let me ask you the point about patients tolerating stents differently is a good one. Clearly, Mr. Kaya had a very, very difficult time with them. Mr. Durkin did a bit better with them. What is your approach to trying to get stents out? You put them in. You have a plan in mind about how to get them out ultimately?
It's if I'm honest, it's tricky, and I think it goes back to this MDT discussion and review of the imaging and review of the anatomy, because taking stents out and being stent free is really the ideal. What I think, if you backpedal a little bit to say, okay, what are we trying to do to preserve a normal life for this person suffering from RPF? And one of which is to protect kidney function. The other is to reduce the risk of complications, and that's what we're talking about here: complications of stents and then subsequently steroids, which is another huge issue. So we obviously want to get stent free, but not at the risk of losing kidney function. And so that's the balance we try and have to play. Medical therapy can really reduce that inflammation, and that's the hope. So if you reduce it enough, you reduce that compressive effect around the ureter, and then you could afford to take that stent out and have urine flow normally down. And that can sometimes happen, but usually you get a feel for whether that's going to be likely even before you start medical therapy, because it depends which part of that ureter is affected and how much of the length is. So if it's a good full length and close to the source of the ureter, you know, where the kidney is there and the ureter plugs in, if it's close to that, then that's quite extensive disease. And I think if you're highly unlikely to successfully remove stents after even medical therapy, because so much of that ureter, so much of that pipe is affected. But sometimes you're in a position where it's just nipped in a smaller region, and you can, with follow-up imaging, you can see that the medical therapy has really reduced that size. And then you're in a much better position to predict a good, successful outcome when you remove the stent. So there is an element of, if I'm honest, guessing, but also it's an educated guess for a prediction of what may happen and what's likely to work and what's not. And I think those people that have quite extensive disease, even despite medical therapy, we tend not to try removing the stent and really consider whether a bigger operation called a ureterolysis is an option. I think we may well talk about that a little bit further on, so I won't go into the detail of that just yet. But it is, in answer to your question, an NDT discussion about the imaging and about response to medical therapy, about whether just removing the stent and watching very closely is an option.
So all of these patients are a little bit different, aren't they? And those differences are driven largely by the anatomy, or at least that's one major determinant: the location of the blockage and the extent of the inflammation and the fibrosis. But one of the things that we hope to do is to get to an effective medical therapy. And so let's pick up the story there.
We had just become aware of IgG4 related disease in late 2007, 2008. And we had begun to treat patients with B-cell depletion in 2008, 2009. So we had begun to develop an experience with it. But you were one of the very first patients we saw with retroperitoneal fibrosis.
That's right.
And so we did not have the knowledge about it that we did then. And it was at a very exciting time, because every week we were learning more about this condition and reading more from others across the world about IgG4 related disease. And so we were confronted with a 58-year-old man, I think, when we met, who had a chronic indwelling stent in the right ureter, and great discomfort from that, and chronic narcotics for more than a decade, and chronic prednisone. And I remember thinking and talking with Dr. Khosrow Shahi, who was the fellow at the time. Are we going to let this gentleman live like this for the rest of his life? Because the current therapy hadn't worked. And we thought, it's worth a shot. Let's give him B-cell depletion.
Yeah.
So we gave you B-cell depletion, 2 infusions separated by 2 weeks.
Yes.
And how did it go after the infusion?
İlk iğneyi verdikleri, Boston'da sana vermişlerdi, hatırlıyorsun. O ilk iğneyi verdiklerinden sonra nasıl hissettin diyor.
Daha iyi, kendimi daha iyi rahatladım.
Evet.
O stent koydukları zaman mesela yürüyemiyordum. Çok yürüdüğüm zaman ağrı yapıyordu. Acayip bir şeydi yani.
Yeah.
Ama İğneden sonra bayağı rahatladım biraz daha.
He said after the first infusion, well, when you told us about the Rituximab and you said, I think that will help you that and we should try it. I was a little nervous at the beginning because I did a big mistake reading it on side effect on Google. And I remember you saying, don't ever do that. And I've never done that since then, actually. But I said when I said to him that if we do this and if this succeed, you might be stent free. And he's like, no matter what, I want to try it. The word stent free was everything for him. He could.
Stent'i çıkarttırdı sağ olsun doktor son. Ondan sonra daha rahatım.
He says after the stent was removed, it was like being reborn for him because that really was bothering him a lot. And when he heard when you said, you might be stent free if this works out, he's like, I want to try it.
Sold.
He would no question asked, and we did. So he had his first Rituximab and we waited a few months after that. And his kidney function was normal. Everything was better. And the day came that we had to remove the stent. I think I'll never forget that day. He was like a little kid. He was like, it's the best thing that ever happened to him. And he's been without a stent since then. Although we did have one episode where, the fibrosis retroperitoneal came back a little bit. We had a little problem, but it didn't take that long.
Another really interesting aspect about Mr. Kaya's case was that we went back and looked at his original biopsy, which at that time had been embedded in paraffin for 12 years. And we made new slides of the tissue and confirmed the diagnosis of IgG4-related retroperitoneal fibrosis then. And we did that, we have done that and continue to do that in so many patients who have had biopsies done years earlier. It's often possible to establish the diagnosis by going back and looking at the original biopsy. Here's Mr. Durkin's treatment.
And then we treated you with B-cell depletion. Can you remember the sort of the sequence?
Oh, we had I think at least 2 infusions.
Right.
And the follow-up MRI, and I think things really started to turn, and they really started to decrease the mass.
Mm-hmm.
And after some time, I guess it had reduced. We weren't seeing any more reduction. There was still some scar tissue left. You referred me to urology at the Brigham for a ureterolysis, so I could get rid of the stent, so they could fix that, and everything's been fine since then, pretty much.
So we will get to ureterolysis in just a second. James, I'm curious about your the sort of timing. And you were fortunate to have the MDT, a multidisciplinary treatment discussions. I tend to, as a rule of thumb, once I start therapy, whether it's steroids or B-cell depletion, I aim to try to get the stents out at about 3 months. And that stems from a discussion I had with basic science colleagues about the timing of peaking of B-cell depletion. So at 3 or 4 months, that therapy typically peaks. And at that point, you have to have a plan. So my plan is usually to try to pull the stents out at that point. And I'm impressed by the fact that very often we don't have to make all of the fibrosis melt away. Even just a little improvement is often enough to be able to get those stents out and keep them out. Do you have a general rule of thumb, or is it sort of a case-by-case basis according to the extent of disease and discussions within the MDT?
We've discussed it briefly before. It is a really difficult decision to make and have a protocol for, if you like, because as you say, that every patient presents in a slightly different pattern with a slightly different anatomy. We tend to be a little bit more conservative, aiming roughly between 3 and 6 months if we're going to try and attempt to take stents out. Do we have a good basis for that? Probably not. It's just, I think it's a feel. Part of the rationale is having enough time for that soft tissue volume to shrink enough. Of course, as you suggest, you do tend to see a fair amount of shrinkage in 3 months, but we tend to try and wait just over that to have a better effect. But also, as you all point out, with retroperitoneal fibrosis, it rarely disappears with treatment. You can never really get it to go away entirely. It's usually what we call a partial response. And some of that we all assume and is plausible plausibly because what's left is the fibrosis, the scarring, and that's very difficult to remove or reverse. You can reduce that inflammation. In truth, there may be some fibrosis and scarring that can resolve over time, but it doesn't really go away entirely. So yeah, you're right. I think you need to have a strategy because you can't leave people with stents forever unless you're really forced to, because when you try, the tubes can block off. What we are adopting a bit more these days is having urologists to pull the stents and at the same time do the what we call retrograde studies. So they'll squirt up some dye under real-time imaging, so they can see that squirt of dye going up the ureter. So they'll take out the stent, squirt up the dye under imaging, and see actually what the flow of urine is going up and going down, whether it drains in a normal fashion or whether it's looking kinked or pinched. Because clearly, if you see the dye not floating up the tube clearly in a consistent fashion, then it's highly unlikely to be a successful stent removal. So they may even reinsert the stent at that point and go back to the drawing board about what we do for the patient.
Nice trick. That's a very nice pearl. So the urologist often has a sense of whether it's going to work or not and can abandon the plan and put the stent back in if it's pretty clearly not going to work. And then if it doesn't work, we move on to ureterolysis, and we'll come back to you with questions about that in just a second, James. But here is another intervention that has to be made for patients, and these are nephrostomy tubes. This is a patient of mine, a woman who had to have bilateral nephrostomy tubes because her ureteral narrowing and blockage was so severe that stents couldn't be passed. And so the radiologist had to insert these tubes right into the kidney to drain the urine and prevent damage to the kidneys. The urine has to have some place to go, so it comes out a tube outside the body and is collected in a bag strapped to the patient's leg. This is not a great way to live. I think you'll agree. This is, to my way of thinking, absolutely not an optimal outcome, not an acceptable outcome if there is anything that we can do about it long term. I am pleased to say that in this patient and in other patients who have had bilateral ureteral stents, we can get those out with effective therapy. And this is the same patient, believe it or not. I took this patient of her on the right about 6 months ago when I saw her back in clinic. Her stents have been out at this point for 2 or 3 years, and she's had a complete return to normal quality of life. You can see how slender she is on the right compared to the left, because it's very difficult to exercise and walk around if you have a bag of urine strapped to each leg. So James, how do you use nephrostomy tubes? Are they sort of a last resort for you when the stents just aren't viable?
Yeah, very much. They're kind of I don't want to dramatize it, but emergency measures. So you use nephrostomies in 2 scenarios. Sometimes on first presentation. So sometimes people would present with bilateral or both sides hydronephrosis. So left and right kidney are blocked and blown up like a balloon. You can see that on imaging because the urine flow is completely obstructed. They're often in kidney failure, so to the point where there's little or no kidney function left. So they can be actually very unwell. So the first priority is what we call decompress. Pop the balloon in a measured fashion. So you'd have to go in through the back, through the skin, and through some of the tissue layers into the kidney and into the collecting system, that central bit of the kidney where the urine collects before floating down the ureter. So those tubes that you see on the left, those tubes are draining the kidney directly and then coming out through the skin and draining into a bag. And we use those in the emergency setting or urgent setting like that. And actually, they can be the route of the stents going in as well. So traditionally, you'd put what we call retrograde stents, so going up, if you like, through the penis or through the bladder. But you can put stents down here. So if people present in the emergency setting, they have nephrostomies, and that saves their kidney function. Usually, you can get a return of reasonable or all kidney function when the dust settles on that, and then you can have stents inserted with the radiologist help through these nephrostomies, and then take nephrostomies out, and then you're just left with this internal stent.
That's really a neat approach. So a retrograde stent actually goes through the kidney first and then down into the ureter.
Sorry, the retrograde stents are the traditional way of putting it in with the urologist, and these would be antegrade stents, so the opposite direction. So you put them from the top down, and then you can take those out. And then the scenario that is in the more kind of elective or planned fashion is having nephrostomies in because stents have been blocked or showing signs of not working so well for whatever reason. And so, yeah, the nephrostomies tend to be a rescue therapy to prevent fulminant kidney failure, if you like, because otherwise the kidneys will stop working if they're blocked up for too long. So it's a useful measure to preserve kidney function until you can, get a handle on the situation, hopefully with medical therapy and/or further surgery.
One of the most exciting things that I've learned from taking care of these patients now for almost 20 years is how rewarding it is, and how much we can help patients who seem to be in dire straits, with extensive fibrosis and kidneys that aren't working because of blockages. But we can very often make a nearly 100% turnaround and improvement, with huge improvements in quality of life. It's enormously rewarding and far from a hopeless situation if you can bring various expertise from different specialties to bear on it. And then the final route of therapy very often is ureterolysis. And you mentioned this earlier, James, and Mr. Durkin actually talks about it here.
Robotic surgery, actually pretty amazing for how, what they accomplished and how deep they went. I stayed overnight at the hospital and left the next day. I had, I think, 3 little nicks on my belly, and that was it.
A laparoscopic robotic procedure.
Yes.
Wow. In the old days, you would have left with a much different scar.
And much later, I think.
Yes, absolutely.
I couldn't believe my wife's driving me home a day later.
So James, the urologists do this procedure typically laparoscopically these days, not an open procedure. Is that right?
Increasingly so, yeah.
There are cases that require an open procedure, a much bigger surgery, I suppose.
Yeah, so the procedure, the ureterolysis, was first done through open surgery. So that means a large incision, usually a midline incision, through which the surgeon or surgeons would directly visualize the retroperitoneum. You can see the aorta centrally, all the tissue surrounding it. And actually, I have gone into a couple of these operations myself out of interest in the patient case, and just to see actually what the surgeon sees. So what you see is really a white rubbery mass. It's not hot and angry and red and inflamed. It's a white rubbery mass that goes around from, as you've shown in previous pictures, around the aorta, and then slowly expands out and starts to infiltrate and envelop the ureters. So it can be very tricky surgery for the surgeons, because it's not a neat thing. So you don't just kind of rub it out the way and free up the ureter. You have to really carefully dissect down to not damage any structures, bit by bit, free up that ureter. And then what they often do is what we call a mental wrapping. So the omentum is really layers of fat tissue within all of our abdomen. And what they use is a segment of that. So if that's the ureter, they wrap it around the freed up ureter, almost like a sausage dog or a hot dog. And so what that does is it seems to protect the ureter from being enveloped ever again by that inflammatory mass if it ever rears up again. And amazingly, it seems to have a kind of an anti-inflammatory, anti-fibrotic property around that ureter, so it can really allow the ureter to function normally with subsequent removal of stents.
The patient who had the CT scan that I showed earlier underwent ureterolysis. And that drove home a lot of those points that you just made for me, how delicate a surgery it is. The tissue of the ureter is potentially quite soft and can tear in surgery. And the fibrosis that is encasing it can be like cement. You describe it as this white rubberish material, and that's not easy to work with surgically. So it definitely challenges surgical skills to do that sometimes. But in the case of my patient and so many others, ureterolysis can be a kidney-saving surgery. So I think that was the last question. We sort of sprinkled in some other questions for you along the way, James. And I want to move now to questions and answers. And many of you have submitted questions, and we'll try to get through those. We've got 7 or 8 of those, and we'll try to answer those quickly in the balance of 15 or 20 minutes that we have. The first question, as someone with RPF, I often feel like I'm caught between multiple specialists who don't always communicate. What can be done to improve coordination of care so I know all my doctors are on the same page? James, I wonder how you approach this in the UK. How do you approach this multi-specialty management? Do you have just one quarterback, so to speak, or how do you try to tackle that?
It's tricky, and sadly, I think whichever country you're based in, it is down to the region and what services are available. That's across many branches of medicine, sadly, and RPF is especially vulnerable to that because you do need the input of multiple specialists. So I think if you have an option is go to what we call a tertiary referral centre, a centre that sees a lot of cases, because you're much more likely to have that infrastructure in the healthcare setting, that hospital, to have a team that have a shared interest and have some form of coordination of that. So often there would be one specialist. It could be any of the urologists, rheumatologists, or nephrologists who would take on a more of a coordinating role in those bigger centres. The other point, I guess, to make, it depends on in which healthcare system you're in, but if it's not in a ready-made infrastructure like that, at least being in the same healthcare system or hospital, because of course medical notes and data and information is so important to have when you're making complex decisions and building a kind of a summary of perspectives. So rather than going from different hospitals that will never communicate amongst each other, if you have an option of trying to group it all into one institution, is always a sound bit of advice. But the other is just trying to put it onto the physician that you're looking at. So so saying, listen, I really need you to help me to manage this condition. It's complex, and I'm going to need some help coordinating. And I think there's lots of polite and subtle ways to influence the clinician's decision making on taking it forward, and you need someone to coordinate it for sure. That's absolutely right. They need to pull opinion and then help the patient through the therapeutic course.
I think that's a great point. What is needed often is sometimes not a person who is an expert on IgG4 related disease, but rather a clinician who is very interested in the patient's care, and someone who is willing to pick up the ball and run with it and achieve the coordination required. So identifying that physician among the group who might be involved, that is probably the way to go. I'll also put in another plug here for IgG4Me, which is the app that the foundation will be issuing perhaps as early as next week. So we'll certainly announce it with great bells and fanfare. That can also be helpful in keeping all of your information together so that the physicians who need to see it can see it. Fantastic. Why don't we go to the live questions, and then we'll get back to the ones that have been submitted in advance. We'll try to get to all of them. Time limited, we will have a hard stop right at the hour-and-a-half mark. But those we are not able to address, we will address in writing and post them on our website. So thank you very much. Let's go now to the first live question.
I was absolutely floored when you mentioned that RPF can cause bloating and bowel changes. I actually spent years, like 2 to 3 years, going through every test imaginable. They were even ready to take out my gallbladder, everything, trying to figure out what was going on. That was like my primary complaint and eventually I ended up in the ER. It got so bad and new pain, and then a CT scan, they found the mass around my aorta. But I am just, like I said, that was a year ago, and I've spent a year just deep diving into this, educating, researching, talking to people, seeing multiple specialists. Nobody ever mentioned that RPF could cause the bloating and bowel changes. So I'm wondering, how is it causing that? Are there triggers that bring it on? Are there ways to prevent it or calm it when that happens?
James, do you want to have a crack at that? I have some ideas too, but you want to have a crack at it?
A couple of comments. You're right. Even in the what we call the medical literature, so published reports and commentaries on RPF, abdominal bloating is not necessarily a prominent symptom that's recorded there, but it is. And we did some years ago now. We did an international RPF study from patients anonymized online. And that was quite powerful to really understand patients' experiences and perspectives. And whilst the mechanism, to be quite frank, is not that clear why you get abdominal bloating and almost bowel symptoms with RPF, it seems to be very, very common. So I think, it was somewhere in the region of 70-75% of patients had abdominal bloating as part of that. It would be complex because, of course, you do get abdominal bloating and differences in how the bowel functions when you're in pain for other reasons. And also, if you're using painkillers, of course, they can reduce how well the bowel squeezes in its normal fashion, and that can promote symptoms. But yeah, if I'm honest, I don't have a good answer as a direct cause, but it's definitely a strong association.
James, that's a really nice insight. So thank you for providing it. I suppose the approach to treatment, then medical therapy, would probably be really essential. So I would be inclined to be aggressive with medical therapy in that setting and use B-cell depletion, especially if there are demonstrable abnormalities in the retroperitoneum. The imaging studies show, for example, a PET scan, which is another imaging study that we didn't mention, if that shows areas of active metabolic uptake consistent with inflammation, I would be aggressive with medical therapy. We have another question live. We want to hear about that one.
We have no rheumatologists whatsoever. Can nephrologists initiate B-cell depletion therapy?
Oh, yes, absolutely. Nephrologists are very well versed with B-cell depletion therapy. I know that answer. And nephrologists treat other patients with other diseases as well as IgG4-related disease with B-cell depletion. For example, ANCA-associated vasculitis is a disease that I know Dr. Tomlinson encounters frequently, and I'm sure you use B-cell depletion a lot.
Absolutely agree with that. Yeah. So not every nephrologist, of course, those nephrologists with an interest in, as you say, John, the other autoimmune diseases, but absolutely, nephrology in general are very used to using Rituximab and would be a good different alternative specialist to use if you don't have a rheumatologist nearby.
The next question that I'd love it if James can tackle is, other than IgG4, serum IgG4, C-reactive protein, and the erythrocyte sedimentation rate, or ESR blood test, what abnormalities in kidney-related blood or urine tests can potentially indicate early signs of kidney involvement? What do you look for, James?
I'm going to disappoint you. There's not a good marker. There's not a good biomarker for this. But I'd say two important things. What we're talking about, almost two things that are directly related. So we're talking about activity of RPF that grows out towards these ureters to threaten the aorta, to threaten the ureters. So imaging is really important because imaging will tell you if the ureters are under threat. We didn't mention a type of imaging here, but it's important to mention on this. There is a different type of what we call nuclear medicine imaging. So using a special type of tracer, using a bit of radioactive material that's not dangerous in the long term, but it's a very useful tool to use to see if the urine flow is normal. So it's a functional test. So that's a very good test to have to see if the kidneys are involved, even before a CT or MRI can tell you that. So that's one thing to say. The other is something about kidney health. So RPF is really important. That's what we'll hear, but it is a rare condition, whereas kidney disease affects 10 to 15% of the population. So it's really common. And the key tests you have to monitor that are blood tests for creatinine, proteinuria, so looking at a urine sample to look at a leak of protein, and the other is blood pressure. And so if you someone with RPF and kidneys are involved or threaten to be involved, you'd need some form of nuclear medicine testing at some point to define the threat of disease, and then also monitoring on most clinic appointments for a serum creatinine, a blood test, urine test for protein, and a blood pressure check.
So simple blood tests, simple urine tests, and imaging studies are really critical to monitoring patients over time. Catherine, is there another one in the chat you want to ask?
You kind of just answered part of it, and because it was related to blood tests. So I'm going to go to the second part of the person's question, which is, would it be best to treat all cases as though IgG4 positive, or treat based on the blood tests, then adjust as needed?
Oh, that's a great question. Are all cases of retroperitoneal fibrosis IgG4 related disease? And does it make a difference, James, in terms of treatment? What do you think?
That's a really good question. In a word, no, I don't think it matters. I think a lot of people, a lot of groups interested in this. I know, John, you've published on this. I saw Augusto Vaglio also in the audience here, who's a specialist from Italy, who's got a long experience in this. He's also published on the treatment of rituximab or B-cell depletion therapy in RPF, whether there's IgG4 present or not. And I think the answer is it's highly likely to be very advantageous, very beneficial to use rituximab therapy, irrespective of whether we think it's married to an IgG4 diagnosis. I think we've all seen a good positive result in reducing the RPF volume and activity with rituximab, even in the absence of obvious IgG4 disease.
That's a great answer. I agree 110%. It doesn't matter so much. Once you've excluded malignancy and infection, if there is inflammation, we're going to treat it in very similar ways. And I think this is not fully appreciated enough in the medical community at large. We need to do a better job educating around this point. It's also hard to differentiate and be certain sometimes whether it's IgG4 related disease or some other cause of retroperitoneal fibrosis, because we often don't get a good tissue biopsy, and patients with IgG4 related disease often don't have elevations in their serum IgG4 concentration. So it can be hard to be certain about that. That was a great question. Let's move on to one more here. Let's see, what are the current treatment options for RPF caused by IgG4 related disease, and how do doctors determine which treatment to use? James, you want to just give us your quick approach to medical therapy?
Quickly, it would be rituximab first. We're talking about medical. I think you should separate in our minds medical versus surgical therapy. Both are very relevant. Medical therapy is relevant to most cases because you want to calm that inflammation down and reduce the risk of progression or relapse with rituximab as a first choice. Steroids can be useful to rescue a situation. You can start them immediately. They're easy to take in tablet form, but of course, as we've touched upon, there are longer term, there are significant side effects. So it's useful to try and wean off that steroid as fast as possible and migrate on to rituximab. And then the other treatment options are the surgical interventions such as the stents and the ureterolysis, and that's to obviously to try and become stent free in the long term and protect kidney function, of course.
And in the States, and hopefully in the UK and Europe and other places soon too, we now have available a new type of B-cell depletion therapy approved by the FDA in April. Inebilizumab is slightly different from rituximab. It targets a different protein on the B-cell surface, CD19 rather than CD20. It's a humanized antibody rather than the chimeric rituximab, meaning that rituximab is made partly from mouse amino acids and is less like the antibodies that that humans have. So it's perhaps more likely to cause infusion reactions and things like that. So there is a new option in the US, which I think shortly may be approved in the UK and Europe and other places as well, inebilizumab. We've had good success getting that approved in the US so far. Let's try to get through just a couple of more questions. Catherine, you want to go through one more from the chat? We've just got 2 minutes. We'll stop right at the 1.5 hour mark.
Absolutely. So there's two in here that seem to go hand in hand. So what I will do is I'll read them both, and then you two can answer as you wish. So the first one, if the RPF is old inflammation without any new inflammation, would this be seen on CT scan, and or what are the best imaging studies? And then the second question that kind of ties into this as well is any role of FAP specific PET to assess fibrotic activity?
Those are great questions. I'll give short answers for them, and James can elaborate a little bit. So what is the best imaging study? That's a bit of a complicated question because you have to make sure you're avoiding imaging agents that may damage the kidney, but we tend to rely on CT scanning. MR scanning is also used, but I think what the questioner is driving at is there some other agent beyond the conventional CT and MR agents? And what we often use is PET, FDG PET, not FAP PET, which is the second part of that question. FDG PET is widely available, and it allows one to understand whether there is increased metabolic activity in a certain area, which typically correlates with inflammation. So if we perform a PET scan in the area typical of IgG4 related disease around the aorta lights up, we assume that there is active inflammation and try to treat that patient as aggressively as we can with steroids, with B-cell depletion. With regard to FAPI PET, that is an imaging agent that is designed to look at fibrosis more than other types of inflammation that's not yet widely available, but I suspect that we're going to be using more of that in the future to be more sophisticated in how we assess these patients. James, are you using FAPI PET at Hammersmith at the moment?
No, actually, no. We use. I agree with all you said, but we're not using more experimental forms of imaging yet. And it's about what you've got access to as well, of course, in different centres. So we have lots of use of FDG PET CT, but actually we're just still building an experience as a radiology centre with use of different modalities to look for fibrosis versus inflammation. But it's definitely a growth area, definitely a strong area now of clinical research internationally, and along with our radiologists, we're working through what can be useful. There are other exciting developments with MRI and different sequences and approaches with MRI, because some protocols with MRI you can differentiate between inflammation and scarring. So I think, yeah, there's a watch this space. I think it's a great, exciting area.
It is indeed very exciting. We're going to have lots of progress in this area of retroperitoneal fibrosis over the next few years. As we wrap up, I promised that I would put the QR code up, so I will do that. But before I do that, I wanted to thank you, James, for joining us very much. Your expertise has taught me quite a bit in a relatively short time, so I'm grateful to you for that and everything that you have taught our listeners. We're going to get to all of the questions. We will answer those and post them in our online community by early next week. So thank you for submitting them. I would like to thank all 4 people, 3 patients, and 1 caregiver who contributed to today, and close with a short reminder about the PeachJAM.
That was one of the striking features of the JAM, the greatest experiences of seeing so many people who said, I've had this disease for 18 years and I've never met anybody else with it.
Yeah.
Really, it was
It
like
was-
being at a big family reunion.
It was so like uplifting to walk into a room and just, once you figure out like, are you a patient? And what do you have? What is, how does it manifest with you? And it was just really fun and exciting to like, you just see everybody's face light up when they'd be like, oh my God, you have this too.
With that, thank you all for your attendance, your questions. Thank you, Dr. Tomlinson, and our patients and caregivers. And here is the QR code. Go ahead and sign up for the PeachJAM now. We'll see you in Atlanta, and we'll see you next month at our next Fireside Chat on vaccines. We'll leave this up for just 10 seconds or so you can all get registered. Have a great weekend.
Thank you, John, and many thanks for the invitation. Really enjoyed it.